I know this thing is on, and I know that you can hear me. Nursing and healthcare needs advocates and activism. So what are you waiting for? Let's do the damn thing. Hi, and welcome back to The Gritty Nurse, an unfiltered conversation about healthcare, nursing, and the intersection of health politics and policy. My name is Amy, and I am The Gritty Nurse. This podcast examines hot topics in healthcare and discusses the changes that we need to see to have a more efficient, robust, and ethical healthcare system that is safe not only for the patients that we see, but also for those who work in the system as well. Sorry, no fluff here, just awesome, compassionate humans and a lot of grit. If you're watching on YouTube or listening on Apple Podcasts, Spotify, iHeartRadio, or any other podcast platform, please hit that subscribe button so you never miss out on any real stuff from The Gritty Nurse. It comes to me as a surprise that I actually have never talked about menopause or perimenopause on the Gritty Nurse podcast. I wonder why that might be. I think it's an important conversation to have with the popularity of various different podcasts about women's health. It is something that we cannot deny, and it's a conversation that we should have. Today, we're diving into the topic that has been too long shrouded in silence, stigma, and a whole lot of suck it up. Our guest today is Shirley Weir. She's a powerhouse. She's a women's health advocate, a TEDx speaker, and the founder of Menopause Chicks. After navigating her own confusing perimenopause journey in her early 40s, Shirley realized that women were being left behind by a healthcare system that often lacks clear, evidence-based answers for midlife health. Since 2012, Shirley has become a leading voice in reframing menopause not as an ending, but as a critical window for health investment. She's here to talk about the grit and the advocacy it takes to own your own body and why normal is not just a setting on your dryer. Welcome, Shirley, to the Gritty Nurse podcast. I'm so excited that you're here. This is the first time I've actually talked about menopause on my podcast, which is really weird because I have a background in women's health. I did my master's degree in it, and I have not touched on the subject of menopause.
Well,
As you probably know, it's right, quite topical, and it is something that we should talk about. So maybe before we get started, could you tell our guests a little bit about yourself and your background?
Sure. Well, thank you for having me, and thank you for cracking open the menopause conversation. My name is Shirley Weir, and I am the founder of Menopause Chicks, which is an online evidence-based education platform for women and community. And what I do essentially is provide that concierge service that so many women and individuals need as they are trying to make the best health decisions for themselves. So we do a lot of, is what I'm thinking true? Where can I find this? How do I know? I was told this. What do you think? And it really is not about me telling anyone what to do, but the ultimate mission of Menopause Chicks is that we empower individuals to navigate these phases of life with more confidence and ease.
Yeah, I think that's something that's well needed because there's so many questions surrounding menopause. There's a lot of great information, but there is also misinformation. And I'm glad that there's someone like you that's out there using an evidence-based lens to talk about these issues and particularly, helping and support women to navigate these conversations. So I think that that's probably the biggest challenge that a lot of women have when we go in and we talk about our symptoms, that we often feel dismissed. And it's empowering to know that there are ways to have these conversations and that we don't have to kind of go through this blindly or without any help and support.
Yes.
And I know you've been doing this work for over a decade, long before menopause was sexy and trendy in the media. So for you, what was the most frustrating brick wall that you hit early on when trying to get professionals and the public to really talk about menopause and take perimenopause seriously?
Great question. I think that probably one of the most frustrating things when I started was definitely not health professionals. You might be surprised to know that the doors that I knocked on, everyone welcomed me in with so much generosity and grace, with their expertise and their time and their experience to explain things to me, because I started this adventure without even really knowing what didn't know. And so I'm so grateful to have tapped some of the greatest experts in this country and around the world. Frustration, or maybe the word that I might use is pushback. So it's that level of uncomfortableness. And I did get that early on, not from strangers so much, but sometimes from my friends or my inner circle who would be like,
Interesting.
yeah, so here's the obstacle that we, still continue to have to get over. It was that I'm not there yet, right? So it's like, I don't need to learn about this until I get to a certain age. And I'm like, really? Don't you want to know? Don't you want to prepare? Don't you want to prevent? Aren't you just curious? And I use that word a lot, curiosity. I find that in our health, we are often not asking, or what's the root cause, or how can I invest in this early to make things smoother for myself? So I love to use curiosity, and I love to work with health professionals who bring that curiosity to their practice and to their work as well.
Yeah, I think that's such a interesting highlight that you mentioned, that it was like even, some of your friends and colleagues that you might have gotten a little bit of this pushback. But I want to kind of bring it back to you. Why do you think that might be? Why do you think that women don't want to talk about perimenopause, or they say, I don't want to have this conversation right yet? What do you think it might be? I
Yeah,
think
well,
I
we
have an
certainly,
idea of what it might be.
yeah, you've already alluded to the fact we have come a long way in the last 13 years since I started this work. So the conversation has certainly been cracked open. But I think the resistance it's a big bucket of resistance. It's ageism, it's sexism, it's a high rate of dismissal and disappointment when we do go to our health appointments and leave feeling dismissed, told it's just part of being a woman, just part of getting older. Oh, it's all in your head. All of those narratives, and that's hard to carry as an individual. And I can't finish that thought without also including the fact that, like, you and I work in the health space. So it's like all day, every day consuming. But most of the general population have very full lives. They're taking care of others, the younger, older. They have full-time jobs. They're volunteering in community. And then we're like, oh, and by the way, I want you to just like stop everything that you're doing. Come over here and learn how your body works because nobody gave you this health class. That's a tough wall to break through.
Yeah, and I would say that there are probably some cultural considerations too. So I would know, like, for example, even in my own culture within the Caribbean, I actually remember my grandma saying that she didn't go through menopause. And I was like, what? What do you mean you didn't go through menopause? And maybe it's just the language surrounding menopause might be different culturally speaking. And I even think about myself. Why haven't I had any conversations about menopause or perimenopause on my podcast? And I'm kind of trying to unpack that for myself. And I think to myself, I'm like, maybe it's because I think to myself that, that is another stage of womanhood that I'd be entering. And that's maybe leaving something behind. So it's like maybe grieving the fact that, my body is changing in this particular way, but it doesn't mean I should ignore it. Right. So for example, like I haven't had the question, but I know that my body is changing, particularly that I had a baby in my 40s, which is wild, but seeing how difficult and how different it was from having a baby in my late 20s. And even just the changes that I'm having, I'm like, okay, this is the start of something different. Like, and accepting that, because I think there's maybe a little bit of resistance on my end to be like, oh, I'm not ready for this change. Why do I have to deal with these changes that it's like waking up and my knees hurting or my back hurting? And it's just, maybe I need to, one, recognize that these things are happening, bring them to my primary care provider and do something about it, as opposed to resisting these beautiful changes that can be in relation to womanhood, and taking that time to understand what's happening with my body and be proud of it. And then also do something about it.
Yeah, you nailed it. You nailed it when you said the word language. So that's a huge part of my work. Is in communications. My background is in marketing and communications. And what we have discovered in the Menopause Chicks community, and I don't think this is specific to any culture. I think it permeates across all cultures. And that is the narrative that menopause equals symptoms and suffering. So
Right.
lean in for this, everybody. Menopause means the end of ovulation. Puberty means the beginning of ovulation. Full stop. Now, once we understand and accept that definition, we can get curious and peel back the layers of the onions. What causes an individual to start ovulating at age 12? It's hormone production. It's messages from the brain to the ovaries that say, make estrogen, make progesterone, develop an egg follicle. Oh, okay. I knew that, or I thought that, or I'd forgotten that, right? And then so the same thing applies at the other end of that hormone teeter-totter, which can be in our 50s. The average age, so we continue to say, is 51. The average age in North America for when women stop ovulating. Why do they stop ovulating? Oh, that production of estrogen and progesterone. First it fluctuates, then it slows down, and then we no longer ovulate. And so much of the narrative is around bleeding. And even I used to speak to that definition of menopause is, the end of your periods, but we weren't getting curious about why we had periods in the first place. And it doesn't
That's
apply
true.
to all people. If you've had a hysterectomy, if you've had an ablation, if you have an IUD, there are many reasons why you might not have a period, but that's not the definition of menopause.
That's so interesting because, again, even the language of menopause, it's like you would say cessation of menses, right? So cessation of bleeding. And I'd say that, yes, a lot of the focus has been surrounding that. So I love the fact that you brought in that new definition in terms of saying it's actually the stoppage of ovulation. And again, talking about, how our body changes and the hormonal changes that we go through. And that's kind of what is the trigger. And I think one of the things that you mentioned in your book is, or a famous line that you had is, normal is a setting on your dryer, which I love. I was like, I saw that. I'm like, that's beautiful. And like in healthcare, we often see patients dismiss their own suffering because it's normal or it's part of being a woman. How can women or nurses or other healthcare providers, start really caring for themselves and start changing that internal dialogue?
Well, I think that I already mentioned curiosity. So if we can get over that stepping stone and really lean into education, I will share with you that if I can figure this out, all of us can figure this out. Right? This does not require PhD level learning to be able to say this, then that. Oh, what's on the menu for my options? And I would, I talk about menus all the time, and I like to steer women towards, okay, here's, 3 different ways that you might be able to prevent suffering, right? Or invest, and invest would be another word. And here are 3 approved ways to treat what you're experiencing, all underscored with a line that says, you deserve to feel amazing.
Right.
And that is profound for a lot of people in our culture, not gender specific whatsoever. A lot of people don't yet believe that we deserve to feel amazing at every age and stage. And so that is step 1. Right? It's not about even going to your healthcare professional. It's not about going to the pharmacy. It's not about building your health team until you actually believe that you deserve to feel well, and to honor and recognize the fact that we are part of the first generation who will stop ovulating and continue to live for another 3 to 5 decades.
Right. Wow.
You
Yeah,
have to believe that.
I think you're right. I think there are a lot of women who feel that, it is normal to have to feel pain, or normal to, let's say even go through painful periods or these different things, and just have not allowed themselves to be like, okay, no, I should feel good. I should be able to take pain management. I should, when I get a pap smear, be able to ask for, pharmacological intervention.
Yes.
And I don't know why we're not there yet. It's
Do
so,
other mammals suffer when they get, I don't know.
It's amazing that it's something that like we have to ask for.
Yeah.
And it's so weird that like we don't feel that we deserve it, but we should. Like whether, and we're going to talk about a little bit more things in terms of, I think one of the things I've come across too is about like, vaginal dryness and these different
Okay.
things. It's just like, we deserve to feel good too. Why? Like, why do we think that we have to suffer? And I think that's a greater conversation, even beyond I'm talking about menopause and perimenopause, because I think it's another cultural consideration, particularly surrounding, misogyny and how medicine operates, that, women aren't at the center. When we can talk even about the research, right? A lot of research studies have been done, including women.
Totally.
And there's just so much more work, but I just think it's so important I like that message. And I think women really should take away the fact that we should be able to feel good at all stages of our life, and that it's not a bad thing to be like, I don't want to be in pain. We don't have to be in pain. And I think that, there's a different way to do things. I want to go back to language and talking about, there is a lot of confusion around definitions.
Okay.
Could you tell women that I think my listeners are anywhere probably between, like, I think I have quite a wide range, like 18 up to like 45 and plus. But can you break down why it's so vital for women in their 30s and 40s to understand the difference between perimenopause and menopause, and what those red flags what we should actually be looking for?
Definitely. Thank you. So menopause, as we mentioned, is defined as the end of ovulation. For most of us, we won't know that we've reached menopause until we go 12 consecutive period-free months if we have a period. So that's like the guidepost or the dashboard that we use. There's a phase of life leading up to menopause called perimenopause. It's quite a new term. It was only coined in 1996. So it's not that long ago, right?
No, it's not new.
And peri, P-E-R-I, the prefix, means around. So perimenopause is very nuanced. It's different for everyone, and it generally means around menopause. I like to equate perimenopause with preparing for the end of ovulation. So your ovaries are actually preparing for a going out of business sale, right? Like business is going to close up. Menopause is just really one day on the calendar that says you can no longer conceive.
Right.
Every day after that is postmenopause. And I like to use postmenopause. I know a lot of health literature will refer to that as being in menopause as well. But I think the more we introduce the term postmenopause, what we're doing is, like, I'm 59 in a couple of weeks. I'm more than 10 years away from menopause, and I'm living my best life in postmenopause. But what does that mean? Right. It means that for probably the very first time in my life, there are new things at the top of the to-do list. Heart health, making sure I walk, not just ad hoc, like go walk, how I used to walk or hike with my girlfriends, but now it's like a deliberate decision.
Right.
That heart health is on the list. Bone health is on the list. Something I did not know when I started this work is the impact of the decline of estrogen and progesterone on our bone density. And we kind of looked at our older people in our lives, like our mothers or grandmothers, and went, poor thing, she fell and broke her hip, as if it was an unlucky event.
Right.
This is not a lottery for women that you just lose. You've lost estrogen and progesterone. So earlier education allows us to be like, well, what do I need to build my bone health? So prioritizing strength building, balance exercises, standing on one foot while I brush my teeth, investing in nutrition, and having important conversations about potential benefits of menopause hormone therapy. And then I know you want to talk about vaginal health, so I'll leave that one. But that's, just something I talk about almost all day, every day, because it has even greater barriers in healthcare. It has even greater rates of dismissal and disappointment. And, my family has been personally affected by underdiagnosed and undercare in that area.
Yeah, I'm glad that you touched on that last piece too, in terms of the underdiagnosis. And I know that, again, one of the biggest issues is that we have these systemic gaps within healthcare. And I kind of alluded to it earlier in the conversation about, historically, women have been underfunded, overlooked. Again, just like as your perspective as a community leader, what do you think is the biggest knowledge gap that currently exists between women who are experiencing what, and what they're being told within the exam rooms? What do you think that we need to talk to our leaders about or our policy makers about when it comes to women's health?
I sound like a broken record, but across the board,
It's okay.
everyone needs to understand the roles and responsibilities of estrogen and progesterone. In particular, we can talk about testosterone as well. But when we understand the roles of estrogen and progesterone, when our cycles are regular, it puts us in the best possible position to make our own health decisions or to help our patients make health decisions for themselves when cycles are no longer regular. If you're sitting across from an individual who's trying to describe vulva and vaginal dryness, pelvic organ prolapse, urinary incontinence, reoccurring UTIs, there should be a bell that goes off in your head that says, she's 59, she's 10 years post-menopause, this makes sense. Her body hasn't had the benefits of estrogen for 10 years. What are
Right.
the approved available treatment options that I can present to her today?
Yeah, no, I think that should be just a part of the regular conversation. And it's kind of bizarre that it's just like, well, we have to trigger sometimes that conversation with our primary care providers. And I'd say that I hope that it is across the board for women care providers, top of mind. But again, it's just like we have to drum it into some of our male counterparts' heads in terms of women's health, that this should be a conversation that's had as well.
Imagine
Go ahead.
taking your car into your mechanic and the tread on the tires are worn down.
Right.
And your mechanic says to you, Shirley, that's just part of owning a car that's been around, it's been around the block a few times. Good
It would
luck.
never.
Good luck, and send us on our way. The risk that we would be putting that car owner or that driver is huge. We do the exact same thing too often in healthcare by sending women on their way saying, good luck with that.
Yeah, you're right. You're 100% right. And I hear the stories time and time again of women feeling dismissed and bringing those symptoms and just being sent back on their way. So again, I think this is a perfect opportunity to have this conversation, to even bring up one of the things that you've mentioned, like it's called the script tip.
Yes.
So, and it was something that you mentioned in your book. So it's literally a sentence that a woman can say to a doctor who is dismissing her. Do you mind sharing what that might be?
Yeah, I've actually been working for the last 2 years with members of the Menopause Chicks community on a method. The background to how this method evolved is a study that was done here in British Columbia called the In Her Words study. It's at inherwords.ca, and it showed or revealed that 54% of women in my age demographic leave our health appointments feeling dismissed or disappointed. That number is significantly higher for Indigenous women and for women of color. And the top 2 reasons for their health appointments in the first place was menstruation or menopause. This is huge.
That is huge.
Immediately after that report was released, it's about 5 or 6 years ago now, the narrative started to unfold in a very interesting way to me. And that was, well, we need more doctors. Well, we need to educate more doctors. Well, we just need to go into our health appointment, slam our fist down on the desk, bring in the 90 pages that we printed off of Dr. Google and demand healthcare. And I'm like, I don't think any of those things are going to work. And I'm all for a doctor education, don't get me wrong, and I'm certainly all for more education, but am I going to live long enough to see the impact of that? Curriculum at medical school is very difficult to change. And so we're not there yet, but we're working on it. Okay, so then I asked the question, what can we do?
Right.
The part of the equation that continues to contribute to those statistics of dismissal is how we're showing up. And I say this very gently because I don't want it to come across as women are to blame. That's not what we're saying. We're saying we're ready to step into the driver's seat of our own health. If we want to reduce that dismissal and disappointment rate, we have to change how we prepare and show up for those appointments. So we developed a program called Script Tips, and I've been testing it over the last 2 years. It's based on 2 acronyms, GAP, GAP, and SPEAK. And the most important part that was missing from how we prepared for our health appointments was that my members were not describing the impact that it was having to their quality of life.
Right.
So GAP stands for goal of the appointment, age that you're at, just so you can maintain eye contact with your healthcare provider, stay your age, say the date of your last appointment so they're not flipping through their notes. And then
Right.
SPEAK, this is for symptoms. We're really good at that. We can go in and say, I haven't slept for 3 months and I'm, experiencing insomnia or whatever you want. You go through the list of the symptoms, or maybe you're only allowed to talk about one thing per
Right.
appointment. A lot of members will tell me about that. But then we would shut up, sit back, and wait for our healthcare provider to tell us what to do. I encourage members to lean in, and that second P stands for impact. And it's to say, my insomnia is now impacting my ability to do my job. My insomnia is now impacting my ability to care for my aging parents. Anytime we can describe personal impact, my vaginal dryness has led to 4 reoccurring UTIs in the last 6 months. This is my 5th time here to get antibiotics, right? It's impacting my quality of life. As soon as we do that, the healthcare provider takes out their own personal judgment. They are, as you know, a scientist. They love data. We've presented the data.
Right.
We've presented the impact, and they can quickly go to what are these solutions that I can offer this individual. And then the A is an affirmation. So I always encourage my members to have an affirmation in their hip pocket. That could be something like, I know that I deserve to sleep through the night. I know that I'm not supposed to pee my pants. I know that I deserve to feel amazing. And it's really that confidence that you're bringing to the conversation. It also helps to level the power dynamic, if there is one, in that team, patient and physician.
Right.
So that's the A. And then K is key next steps. And that's really the decision-making part of the healthcare appointment, where you're like, I'm here to invite you to help me decide what is the best next step for me.
I think that's amazing. And I think that is something that is going to help many women. And I would even like to even add on to it, not to the script piece, but to the fact that, if you have this conversation and you use that type of dialogue and you still don't feel satisfied with the outcome, I've told people that I think it's absolutely fine for you to seek another care provider. If you don't feel that you're being listened to or acknowledged or your symptoms are being dismissed, sometimes it might be, it's time to find someone else who might listen. And I know for some people that's hard to say, maybe they've been with this doctor for many years, but if they're not listening to you and they're not understanding or acknowledging your symptoms, then it might be time to find someone else. Yeah. So I love all of those tips, and I think that they're amazing. And I just want, like I said, just add on that other piece. If you're not being listened to, then it might be time to find another practitioner. I
struggle with that because so many Canadians don't have a healthcare provider and they aren't able to go down the street and shop for someone else. But definitely you're in the driver's seat. You get to choose who is on your health team. And I would add to that suggestion, don't fire your primary care provider. But they might not be the expert that you need in this particular situation. So you can add to your health team and you can still keep them as your primary care provider.
Yeah, because I do know the other piece is, and you talked a little bit about like health equity, that there are a lot of women that suffer, racialized women that suffer with like fibroids or endometriosis. Yes. And that is a huge challenge and a huge barrier to get, additional testing done or to actually have them removed. I know of individuals, I have my own cousin herself who went to LA to get her fibroids removed because it was going to be 3 years here before she would have even got to see somebody.
Wow.
So sometimes that advocacy piece has to be kind of leveled up to say, okay, if you're not hearing, I need you to help support me in this way, or I need to see this other individual for you to help. Because again, I don't think as Canadians, we should have to leave our system to get adequate care or help and resources. And again, when we look at the wait times related to endometriosis surgery or
Yeah,
fibroid
for
surgery,
sure.
it is so high.
For
And
sure.
we see that disproportional impact of, racialized folks. And again, it's just adding that extra burden that should never
Yes.
be there when it comes to women's health. So again, we will
Yeah.
look at, I think as a whole, we have to suss out all the solutions that are available to us. And like you said, remember that at the end of the day, we are in the driver's seat of our own health.
Yeah. And before we get into that driver's seat, like we can bring more to that conversation. So I think what might have happened in the past is that you might not tell your healthcare provider that you're leaving or that this is your last appointment or that you'll never be back or that you want to add someone to your health team. I have a wish, and I don't think I might not live long enough to see it, but I'm like, wouldn't it be great if our healthcare providers felt confident enough to say, Shirley, that's not in my wheelhouse. It's not something I studied. I think we have to develop a plan for where you're going to get the best care. Okay, so that would be ideal. But if
that would be ideal.
But if that's not happening, it is okay. Here's your permission slip as a patient. It is okay to say, it sounds like endometriosis is not in your wheelhouse. I'm going to build my health team out and I'll be back to tell you what I decide to do.
I think that's a fair conversation too.
Yeah.
And I think that's very empowering that an individual might be able to have that conversation. And I know that some people struggle with that.
Yeah.
And this is where I also say, when you go in for your appointments, be prepared. I always bring we have powerful computers that we walk around with phones, write the notes down.
Yeah.
Like I use notes all the time to be like, all right, I know I only have one time that I can be talking to you about all these issues, but I'm going to get everything out in this, one I think it's like one issue per visit, which is a whole other conversation.
Well, and white coat syndrome is a real thing too.
Yes, it is.
Especially for women, is that we kind of lose our train of thought easily. I know that myself. And you get to the appointment, there's some anxiety maybe built in, or maybe it's a past experience that just continues to linger and disrupts your ability to communicate. So all of that is very real. Definitely take notes.
100%. So I'm going to circle back to what we were talking a little bit earlier about, which was would you consider yourself a vagina health evangelist?
I am. I would.
I saw that. I thought it was a hoot. So why is there such a pleasure gap?
I even have my Christmas tree
around. Sorry?
This is my Christmas tree decoration.
I love it. Why do you think there's this silence around general urinary health, talking about, vaginal dryness or atrophy within midlife? Because, sexual health is important and it shouldn't be a luxury. Why do you think that might be?
Probably some of the same reasons that we've already talked about, systemic silence, systemic dismissal. And this might not make me the most popular girl on the block, but we keep a lot of things. We internalize a lot of things. We tell ourselves story like, oh, I must be the only one, right? Oh, this is happening to me, but, I can't talk about it with my girlfriends because what will they think? All of that. I feel that that's actually breaking away. I've seen my daughter, who's 22, talking not only just with her peer group, but on TikTok about things that are happening to her. She has a PCOS, polycystic ovarian syndrome. She's talked about bleeding through her genes, so I am very optimistic about future generations, but we have sort of inherited this culture of silence. The other thing that really impedes us from having informed conversations is that lack of understanding and lack of education. For example, vulva and vaginal health is not sexual health. Sex and insertive sex, because there are many different types of sex, is, related to the vagina. That's not the only game in town. And it's kind of a narrative that was fed to us early on and then continues to, older people being treated by healthcare professionals who think that penis and vagina is the only thing that matters. And it completely shows up when we look at the treatments that are available. I'll say vaginal estrogen, and I'm a huge advocate for vaginal hormone therapy, but it ignores the vulva. And they're all skin cells. skin cells are on the outside and some skin cells are on the inside, but we have like really effective treatments called vaginal hormone therapy that doesn't treat the vulva.
Interesting.
It's crazy to me in a way.
Well, I mean, again, this is why we're having this
Yeah.
conversation. And I think you're right. I think, I don't want to say it's like my generation, but I do feel that, we're a little bit more open to talking about our bodies. And I think it's very empowering to be able to have
Totally.
these conversations. And again, my background was labor and delivery. So, I mean, vaginal health was very important to me anyways, because it was also a part of my world. And I think we should never be ashamed. I think, one of the things that I remember having conversations with my mom about was just even around anatomy. Cause sometimes even here's that cultural piece, people don't even look down there. And it's just like, you need to know what your vagina looks like. You need to have an understanding of the norms and what might be abnormal, because again, there are risks to cancers and various different things. And if you don't look, then you don't know. And I would say it's such a huge, important part of your body. Why not really truly understand it? And again, it should not be there should be no shame surrounding the vagina. That's just my little piece there.
So this is how like I've evolved and learned over the last dozen years. I have a 25-year-old and a 22-year-old. I delivered 2 babies vaginally, and nowhere along the process was the term pelvic floor or pelvic
That's really sad.
mentioned. Not even mentioned. So
That's sad.
in 2019, my son was 19 years old before I went to my first pelvic floor physio appointment. My physiotherapist asked me questions about my delivery and my scar tissue. And I'm like, just completely blown away by the quality of information and education. And I always say, it's never too early and it's never too late. So it's never, ever too late to learn and to even course correct if you're having issues, pelvic floor issues.
I love that. And I love that it's never too late, because I think some people are just like, well, that time has come and gone. It's like, nope, still attached to your body.
Yeah, right? And you only get one.
So let's make sure we look after it, right? This conversation has been so enlightening. I've learned so much from you as well. And I think that, we can continue having conversations. But, before we leave and wrap up, you often speak about menopause as a milestone for celebration. If we view menopause transition as an investment phase for the next 30 to 50 years of our lives, what are maybe just one of the top priorities? And I know you talked about brain, bone, and health that women should be discussing right now.
My goodness. Well, a phrase that I'm using right now is the joy of menopause, and really leaning into that. And I think that because there is a lot more noise for us to contend with in media, social media, and all the circles that we're playing in, it can very quickly turn into a negative conversation. There definitely are some barriers and some gaps that we need to overcome, but we can't let go of the fact that this is a time in the life that not only are we no longer having to worry about contraception, no longer dealing with the inconvenience of a period, we're also leaning into what we want. So our own name is at the top of the to-do list, and that might lean into other areas of your life, such as, what do I want for my sex life? I hear from women all the time who are like, orgasms were never like this before. But maybe that's because you had, a house full of kids, or just so many roles and responsibilities, and you were sleep deprived, and now you found a way to prioritize your sleep. And guess what? All the other things like eating and sleeping and moving and enjoying amazing sex with or without a partner is on the menu now. And so, I talk about that. I also talk about, the people that I have the pleasure to work with every single day who share stories like they're changing jobs, or they're running marathons, or they're running new businesses, or they're running for government. Like, it's really that force of empowerment that maybe it can only come when we have the luxury or the wisdom or the joy of menopause.
I love that. My goodness. Thank you so much, Shirley, for coming on the Gritty Nurse podcast.
You.
Such a fruitful conversation and just so much more things to kind of think about. And I love the way that you've packaged everything. And I think I actually what I'd say is I think there's so much that women will take away from this conversation. And I hope men too, because we do have men listeners as well.
For sure.
That, that they shouldn't be shying away from these conversations either. Thank you so much for coming on. Your wealth of knowledge. I'm sure we'll have to catch up and have another conversation. Maybe we just have a conversation about sex after your 40s or your 50s. Okay. I think that would be a fun conversation to have.
But
again, it was an honor to have you on, Shirley.
Thank you so much. I could do this all day. I love it.
Okay.
All right. Good.
Looking for a great gift for a nurse or someone who needs to learn about nursing? Check out my national best-selling book, The Wisdom of Nurses, Stories of Grit from the Bedside. Thank you so much for listening to The Gritty Nurse with Amy Archibald-Burley. If you're watching on YouTube or listening on Apple Podcasts, Spotify, iHeartRadio, or any other podcast platform, please hit the subscribe button so you'll never miss out on any awesome episodes from The Gritty Nurse. Thank you so much and stay tuned until next time. Stay gritty.